afternoon, everyone, and I welcome you all to the 103rd session of e-NISCHIT. And it's my privilege and pleasure to welcome you all from all the centers across the India. So today we are going to have a very interesting case, but first I would like to introduce our panel to it. We have Dr. Upasna ma'am with us, who's the in charge ART Center and Head of Internal Medicine and Hospital Administration at NITRD. And we also have Share India team, which helps us supervise Ms. Dr. Jyoti and Mr. Rakesh, who helps us in logistic and IT part. So I welcome you all. And today we have a very interesting case with us. It's a case of Pott's spine that we are going to discuss today. And as we know that extrapulmonary TB is a very formidable enemy in eliminating TB for us, because it's very ambiguous, the both diagnosis and management of extrapulmonary TB, especially when it comes to spine TB. So I'm sure that all of us are going to really enlighten ourselves and be very enriched after the end of this session in what to do in such cases. So I would like to first tell you I introduce our case presenter to you. Our case presenter today is Dr. K. Babu Shreedhar, who's Senior Medical Officer, New GGH, Vijayawada, Andhra Pradesh. So thank you, sir. And as an expert, we have Dr. Nishant Soni, who's a Senior Orthopedic Surgeon, and he's Senior Consultant at Puspawati Singhania Hospital and Super Soni Specialty Orthopedic Center. Thank you, sir. Thank you so much for joining us and being the expert for today.
So let's request Dr. Babu to please make his presentation.
Good afternoon, madam.
Good afternoon, Dr. Babu.
Dr. Shreedhar, SMO, ART Center, Vijayawada, madam. Age 27 years, female. Attended the ART Center on November 9th, 2021, madam. And the ART initiation was done on the same day, that is November 9th, 21. After registering the patient, IPT was started on December 3rd, 2021 and ended in May 2022. In the month of February 2022, the patient came with, was referred to the neurosurgery department, and they diagnosed it as Pott's spine, D5 and D6 levels. And ATT was started on February 2022 to January 2023. That is for 10 months. The ATT was started at the advice of the neurosurgeon. At first, the patient was on ART, that is on TLD, on November 2021. But later, the patient developed Fanconi syndrome, so the drug was substituted to ALD plus CPT is given for 6 months in the month of December 2021 and May 22. Duration of treatment for Pott's spine is for 10 months. Issues for discussion are: what are the chances of recurrence in Pott's spine after 10 months of therapy, and how the physiotherapy will be helpful for the patient.
So thank you, Dr. Babu. That was a very interesting case. And before we go ahead, I will summarize the case. I just need one information. This FNAC was from what place? Was this from a lymph node?
Yes, madam, lymph node.
Okay. So thank you so much. So I'll just summarize the case for the benefit of the house and the benefit of our expert. Well, this is a 27-year-old female. She was 55 kgs and she was already taking ART from the private sector since March 21. Then she came to the Vijayawada ART Center, which is a government HIV center, on 9/11/2021, where her ART, which is something known as a TLD, that is tenofovir, lamivudine, and dolutegravir, was continued. However, what happened was that they found a lymph node while the patient was with them, and FNAC was done, and the FNAC was suggestive of tuberculosis. And they started this patient on anti-tubercular therapy on 25th of February 2022. That is, the patient comes to them in November, and in February they find that the patient has active tuberculosis. So the patient is started on ATT. Now, while the patient is on ATT, approximately 3 months into ATT, the patient develops severe backache with paraparesis. Now, this was worsening of tuberculosis while still on treatment, something that we would like to call immune reconstitution inflammatory syndrome, the TB-associated iris that we call. And it was found that the patient has Pott spine with dorsal myopathy when they consulted a neurosurgeon. And the MRI showed that there was wedge compression of D5, D6, D7. They have an initial CD4 count which shows 94. So despite the fact that she was an ART from private sector, I don't think the ART worked a lot, because when she came to them after about 6 months, she was still very immunocompromised. And we do not have a viral load, but we do have an information that TLD had to be shifted to ALD because the patients developed some kind of renal toxicity. So the issues for which Dr. Babu is actually has brought this case today to this forum is that he wants to know what would have been, or what is, or have they given the ideal treatment for Pott spine? What would be the supportive treatment as far as physiotherapy and other things are concerned? And what would be the chances of recurrence, or how can we diagnose a recurrence in case of Pott steel? So with this summarization of the case for the house, I think before we invite our expert, I will hand over the mic to Dr. Ananya.
Okay, now it's time for us to invite our expert for today, Dr. Nishant. He's a senior orthopedic surgeon, and he's a senior consultant at Soni Super Specialty Orthopedic Center and at PSRI, with that PSRI New Delhi. So, sir, it's a pleasure to invite you. And he has immense experience. So
thank you so much.
Thank you, sir. Thank you. So we can go ahead with your dialectic, sir.
So, first of all, I would like to thank everybody with involved in this initiative. I really was very impressed with what you guys are doing. I think it is very important that we get on board other consultants and to teach regarding, the management in the proper way. For the case, I think we will start with the presentation. And so today, this case that we are discussing is from Vijayawada, and the patient is a known case of HIV positive status, and she was on some, she's 27-year-old and she's been positive since 2013. She was taking Trimune 30 on her own from a private practitioner, I feel, and as per the history, and then she stopped the ART during COVID, and then again started on Nevilast. Next slide. During the treatment on these two therapies and during this period, and in August, she developed of 2021, she developed cuff and cervical lymphadenopathy, and she was diagnosed with tuberculosis and started ATT in February of 2022. While on ATT, and also the ART was changed for her, she was put on the TLD program, which you people initiate now. So while on TLD, she developed the low backache and she started developing weakness or paraparesis in both her lower limbs. And the MRI done at that time at the center showed that she had a diffuse multilevel Pott spine, especially a wedge collapse of D5, 6, and D7 vertebral bodies. Patient has dorsal myopathy. She was referred to a neurologist. She was continued with the ATT and ART, but still continuous weakness and myopathy, and she's bedridden since February of 2022. So this MRI was shared with me, which has been done in October of 22, which showed that she has got a focal kyphotic deformity, which was there in the first MRI also. So this is the follow-up MRI. There is an altered signal from D1 to D10 vertebral bodies, which shows an active disease. There is wedge compression fracture of D5 and D6, and there is a big epidural collection around 8 mm thickness at D5 and D6, causing compression and spinal canal stenosis. There is reduced height of D8, anterior wedging, and also there is another collection which is from C7 to D9. and with the maximum focus being at the C5 to C6. So this is a diffuse Pott spine in an HIV positive patient who is on ART and also on ATT, and it has been progressive without any relief from her symptoms. Can we go on to the next slide, please? So there is a lot of theory involved in how to manage this patient. So I'll come down only to the most practical points that we need to understand. So first of all, in any Pott spine, what are the clinical factors which influence the prognosis or the behavior which the patient would show as far as the treatment is concerned? So first of all is duration, whether it is a short duration disease or a long or a more than 12 months, symptomology and disease. What was the speed of the onset? Whether the disease started and progressively, started showing symptoms, or was it a very rapid development where the patient suddenly developed backache and followed in a few, in a few weeks or months, patient started developing neurological symptoms. How old is the patient now? This patient is quite young. She's 27 years old. Whether the disease is active or whether the disease is already healed. What is the status of the cord on the MRI? Whether the cord looks normal on the MRI or whether there are already myelomalacic changes or serings, because these changes signify that the disease process has caused the blood supply to the cord to disappear, and so certainly causing a sort of a ischemic cord this thing, and where the recovery signs are very, very less, or recovery is very guarded in these patients. Whether the kyphotic deformity is less than or more than 60 degrees, what are the status of the lesions? Like in this patient, the lesions are showing a collection. So they are wet versus dry, which lesions which show that maybe the disease process has now settled down or has been there for a longer period, or maybe on an ATT, what was a wet lesion to begin with has now become dry after starting the ATT. That means the patient is responding to that. Long duration, the first point, if the patient has been having a disease for more than 12 months, that means the patient might develop a myelomalacic change or a serings formation in the cord, where even after the treatment, the neurological status might not improve. So the treatment has a guarded prognosis. So these are the various clinical factors. Can we go on to the next slide, please? So the most important thing is to understand that all tubercular Pott spine patients or spinal disease patients do not require surgery to begin with. It has been well researched and well documented, and it is our middle path regime, which is the conservative regime which we follow, which was suggested by Dr. S.M. Tooley in the north, and also by Dr. Rajshekharan and group in the south, where we were starting the ATT. And obviously in this patient, the patient has to continue with the antiretroviral treatment also. Patient is advised absolute bed rest. Absolute bed rest means even for self-care purposes, the patient needs to be in the bed. There is supervised care. Some doctor or a healthcare representative is following the patient on a regular basis. There is regular neurological assessment, and patient is undergoing a good quality physiotherapy while in bed to help her. There is use of splints and braces. Once after 6 to 8 weeks of complete bed rest, we want to start mobilizing the patient. We have to advise the splint and spine braces to begin with. And then at 3 months, or when the neurological recovery is complete, we ask the patient to start mobilization. So this is basically a sort of an immobilization for a longer period in a patient of a Pott spine with neurological deficit. For example, a patient develops neurological symptoms while we have initiated the anti-tubercular treatment and progressive in nature. Again, we can put them on a complete bed rest. We can do the supervised care, neurological assessment regularly, blood works. And then once the neurological recovery starts appearing or is complete, we can again mobilize the patient. And the ATT in all Pott spine has to be for at least a minimum of 1 year. So we will start with 3 months, 4 drugs, plus 9 months. Next 9 months, we will give three drugs to the patient. Usually, we start with rifampicin, ethambutol, pyrazinamide, and isoniazid to the patient for the first 3 months. And then after that, at Once this drug regime is complete, at 9 months, we continue with rifampicin, uh, uh, isoniazid and pyrazinamide for the patient. Can we go on to the next slide? These are the various braces while on treatment when we want to start the patient to mobilize once the neurological recovery is complete and we feel that now the patient can be mobilized, we start using these braces to support the spine. So this is a TLSO, which is a shell thoracolumbar orthosis, which can be used, or something like a Soni brace, which is a sort of a cervical appliance which can be applied and the patient can be mobilized with that. But the main point is the neurological deficit should be recovered. Next slide. So when do we decide to intervene surgically? When we see that there is no neurological recovery while the patient is still on conservative management and it is being strictly followed. There is sudden deterioration of neural status of the patient while the patient is on ATT. There is MRI, repeat MRI, which shows a collection or a block on the myelogram. A spinal tumor syndrome, which is a diffuse extradural granuloma on the MRI, is a direct indication for urgent surgery or decompression for the patient. Can we go on to the next slide? So what could have been done for this particular patient, who is a 27-year-old, started the ATT in February of 2022, and there was no recovery for the neurological deficit of the patient, and the problem was continuing. When we understood that there was no improvement on the neural status and the strict middle path regime was being followed, we should have repeated an MRI at the earliest. If on MRI, we would have found the same problem, that there is a diffuse spinal involvement, there are 2 or 3 places where there are collections which are present, we could have gone in for a posterior decompression and debridement, especially at the cervical and dorsal spine level for this patient. And during the perioperative approach, we could have seen that there is instability at these involved levels. We could have gone ahead and fixed the spine to give it more stability. We would have continued the ATT and ART even after the surgery was done, and could have even started the patient on a middle path regime again, where absolute immobilization was indicated. And we might have had to re-intervene at times if we are seeing that the patient is not recovering, or on subsequent MRIs, we again find that the patient has got a recollection which has developed there. We could have gone in and re-debrided it again. All this while the ATT and ART has to continue. But obviously, we have to understand that once the patient is stabilized and is ready for a surgery, like for this patient, when I saw the investigation, at one point there was a low hemoglobin level. He had a very, very low CD4 count, and maybe those were not the right time. That was not the right time or indication for the surgery. But then she could have been, approached medically, made better as far as her clinical status was concerned, and taken for surgery as soon as possible. Next slide. So this is an example of a tubercular spine where we can see there is a kyphotic deformity on the X-ray and the CT scan. The MRI shows that there is a big compression of the cord at the dorsal spine level, and subsequently it has been decompressed. It has been fixed with rods, screws to give it stability. Maybe there is a collection which could have been evacuated. Next slide. So what is the learning with this case? We have to diagnose and start ATT with middle path regime. We have to watch out for the red flags: worsening neurological status, no improvement in neurology, the patient having more, like for example, a patient of a dorsolumbar tuberculosis developing, weakness or symptoms in the upper limbs, patient developing signs of drug interactions, or liver function is deteriorating and we have to modify, then we have to be even more careful, because doing that, we might be giving a chance for the disease to, progress even further. So during this period, absolute clinical assessment and good, follow-up should be there. Maybe need to modify the ATT, especially rifampicin if drug interactions is observed. Timely surgical intervention can prevent a lot of damage for the patient. Syrinx, if seen on the MRI, is a sign of cord ischemia and has guarded prognosis. Next slide. Thank you. Any questions or anything that you would want to ask? Please welcome to do that.
Thank you, Dr. Soni. That was actually so crisp and so to the point. I'm really amazed how you covered such an important topic in such few slides and sent across the message. As part of the program, we have to summarize the presentation. So I'll do that for the house. If anywhere you feel I have missed out something, please do add to it. So just to summarize what Dr. Soni said, this is a case of diffuse Pott spine. And he told us that there are certain factors which determine the prognosis in a case of spinal TB. One could be the duration of the disease. If it is more than 12 months, then there is a high probability that the spinal cord itself is affected. Now, other thing that affects is whether it's a slow or a rapid onset, whether the age of the patient is old, whether the disease seems active, or maybe it looks like a well-treated or a dormant disease. Is the cord on MRI showing any changes? That means that the blood supply of the cord has been affected by the disease process.
Ma'am, I like to add something here. So
Yeah.
even if in a case where is a known case of Pott spine has been given ATT, and we see on subsequent MRIs that the disease process has healed. Patient has got neurological recovery, everything is fine, is doing. But when they start developing a back pain again at the same point, or an MRI or a proper radiological investigation is indicated, because even in healed tuberculosis, recurrence can occur as such. Or another place, for example, a patient of a dorsal lumbar spine disease, which is healed, proper ATT taken, but now starts developing a cervical myelopathy. It needs to be evaluated, because again, the first thing that we need to keep in mind that there was a case of tuberculosis of the spine here, and we could be having another focus somewhere else. The second thing is that what is the most important thing for these patients to see is that I don't know whether the MRI has, I have not seen the films. The report was forwarded to me. So in that, there is no, report on the condition of the cord for the patient. That could have really prompted us to, understand whether a surgical intervention earlier than required could have been taken up. So that was one thing. Other thing is that it's tuberculosis, osteoarticular tuberculosis is very difficult to treat. In fact, previously, till the new regime or the new guidelines have come, we used to give at least 18 months of ATT to the patient. And in that, the major follow-up we used to do was with ESR and CRP. Plus, if the patient can afford, we would like to get repeat MRIs done. But most of the time in centers where MRI is not available, ESR, CRP, general condition, neurological recovery, these used to be the signs where we used to decide whether the ATT needs to be continued or not. In immunocompromised patients, though, there is I think, and the need for ATT or to modify it is there. So what I was understanding was that rifampicin is one of the drugs which interacts with the ART treatment that is being prescribed. And then yeah. So I would like for my knowledge to know then.
Yeah.
I've read the guidelines, but still, ma'am, if you can tell me.
Yeah. So the ART regimen, TLD or ALD, which they say it's a 3-drug regimen, and the dolutegravir for anybody who gets rifampicin is given in double dose to overcome their drug-drug interactions. So if I have to give a rifampicin-based ATT, because ATT without a rifampicin falls way below in its efficacy. And we are, as TB experts and HIV experts, we are never comfortable giving ATT regimen without rifampicin unless and until it is a drug-resistant TB. So the selection of TLD by the national program has taken this fact in consideration that we would need to treat a lot of TB patients along with that. So in which case, what we do is for this patient, they would have prescribed TLD in the afternoon and one extra dolutegravir 50 milligram in the morning to overcome the drug-drug interactions.
I saw the drug sheet, they have done that.
Yeah. So I'll just sort of summarize. Most of the discussion has actually.
Post one also.
So please post, the post test is also coming on. So while we are doing the post test, I'll just repeat a few salient points like what Sir said. So not all cases of Pott spine need surgery. We have to follow what is called the middle path regimen or the conservative treatment, which basically means that you start ATT and of course in this case ART and absolute bed rest even for self-care. It's not as if you can go to the toilet and you can go and have a bath and then come and lie down. So it is absolute bed rest and there should be good supervision. There should be a constant neurological assessment and physiotherapy while still in bed. After 6 to 8 weeks, depending upon how the neurological status is, you can try to mobilize the patient with the help of splints and braces. And you should only advise mobilization after the patient has had a good neurological recovery, which is at least 3 months from the start of ATT. And as we know that ATT in cases of spinal TB, we have to give at least for 1 year. And it can also be extended to 18 months depending upon the response of the patient. This is the extrapulmonary TB guideline. The first 2 months we will give RHZD, that is rifampicin, INH, pyrazinamide and ethambutol. For the remaining 10 months or 10 months plus or the remaining 16 months, depending upon how long you are giving the treatment, it will be RHE. That is rifampicin, INH and ethambutol. Then sir also told us that what could be the indications for surgery if you see that there is no neurological recovery on ATT. Or you find that while on ATT there is a sudden deterioration. Or you get a follow-up MRI done and it shows a block in the card. Or there is a diffused extradural granuloma for which needs decompression. So these are the cases where you would need surgery along with your ATT and ART. In this particular case, sir told us that an MRI should have been repeated and possibly it would have been a good idea to do a posterior decompression and debridement that would have helped the neurological recovery of the patient. The spine could have been fixed surgically, and of course, ATT and ART was to be given. And as far as the recurrences are concerned, which was one of your concerns, Dr. Soni has very clearly told us that recurrences are always possible. After given a whole course of ATT, the patient can again develop back pain in the same area or probably even another area of the spine, which would mean that a recurrence has occurred. So that is something that we have to remember. If a recurrence occurs, again, we have to walk the entire path. We have to start ATT. We have to see that our ART is effective. Because any surgical intervention or any response to ATT cannot come until the immune status of the patient is built up. So we have to build up the patient so that he is ready to respond to the ATT, the conservative management, or the surgical management, whatever may be needed. So with this short summary, I'll just like to ask Dr. Babu, have your questions been answered?
Yes, madam.
Would you like to ask our expert something else?
No, madam.
Can I ask the house if anybody has any comments?
We have four.
Okay, so we have 4 questions. Dr. Ananya will read them out. Dr. Soni, there are 4 questions. Please, could you help us with that?
Yes, ma'am. Please tell me.
So, okay, so somebody asked, that was the ART question, that why was TLD changed to ALD? There was a renal failure. It was there written somewhere in the case presentation. Probably you missed it. That's why TLD was changed to ALD.
Yeah, patient developed Fanconi syndrome, it seems. That is why it was.
Dr. Sachin wants to know if there were any reports to support nephrotoxicity. There must have been, sir. And because we are discussing TB more, that's why we don't go into the absolute nitty-gritties of KFT. We believe the ART centers. But Soni, can we please ask you? Somebody is asking, what should be the best approach for pain management if somebody is already on bed rest and doing physio, but still in severe pain? What should be done for this patient?
Yes, so neurological pain is a big problem because the patient, first of all, there will be pain because of the involvement of the spine, as well as because of the pressure effect and all that happening there, pain will be there. So gabapentin is a good drug to use in these patients. But we have to understand something with gabapentin. It's a double-edged sword. It's not like I can continuously keep on giving gabapentin to the patient throughout the treatment till the time they come and complain, because it's a habit-forming drug overall, especially pregabalin. So we have to understand that we have to modulate our gabapentin accordingly. And once we have started, it is not like we can withdraw it completely also.
Yes.
So gabapentin can be started to the tune of 300 milligram, 2 tablets 3 times a day, 600 mg TDS, and then slowly we can take off one drug at a time. But obviously sedation will be there. During the time we are treating the patient on middle path regime, there is no problem. The patient is recumbent, they are lying on the bed, they are resting. And at that time, yes, some sedation is all right. But once the patient starts mobilizing, slowly we have to withdraw the gabapentin. Other drugs which we can use is amitriptyline, which is again a good drug. So we sometimes use gabapentin and amitriptyline together for neurological pain as a management. But these are all nerve sedatives. So we are just sedating the nerve. Rest, everything else the ATT has to do. The rest has to do. Rest in itself causes the pain to disappear slowly. A disappearance of pain on ATT in such patients is definitely a positive sign that the treatment is working.
So this is another pearl of wisdom. I tell you, in the periphery where we are sitting in ART centers and we really don't have much to offer in way of MRIs, repeat MRIs to our patients, please remember a disappearance of pain on ATT should always be taken as a good sign. Until the patient is in severe pain and bed bound, you could give gabapentin 600 milligram 3 times a day, or even amitriptyline. But once you start mobilizing the patient, see, these are nerve sedatives and they're also CNS sedatives. So you cannot risk a fall or the patient having chakkar and then falling. So please gradually taper them off as you start mobilizing the patient.
Other thing is that even if the pain is disappearing, please remember neurological recovery should be there. It's not like pain khatam ho raha hai, because when the pain is disappearing, it can be the other side also, that the cord is so badly getting involved that now that the paresthesias are completely disappearing because all the sensory inputs are missing. So we got to understand that local pain disappearing is good. Second thing, logical recovery is the other good sign. So plus ESR and CRP are two, and I do not know how we can take them on patients on ART as such, or immunocompromised patients as a measure of recovery from the disease.
So they can be taken for patients on ART. They are good measures of inflammation.
So these signs plus ESR, CRP, which is getting better on ATT, patient, developing better neurology, patient developing less pain at the local site. These are all good signs for on ATT for recovery.
So there is a question that somebody says, how can we diagnose drug-resistant Pott spine? So for that, I would actually say that we need a sample. So what I would like to ask you, sir, how can we take a biological sample in Pott spine, which we could probably send for microbiological testing?
So all we need is a clean OT environment and a C-arm machine. We can localize the disease on the C-arm where the disease vertebra is there. We can take a needle. We can just give a sort of an epidural or a peri-epidural sort of around that area wherever the abscess is. We can obtain a good sample and send it for our Ziel-Nielsen staining. We can send it for PCR for TB, or we can send it for all the assessment that we do for multi-drug resistant. TB multi-drug resistant, and that should be there. That is one of the prerequisites before we start patient on ATT for tuberculosis of the spine. Here, the patient had lymph biopsy which was done, FNAC was done, and the sample was sent, which came out to be positive for TB. That is when the primary focus, the treatment was started. So there are a few things which we need to do before we start the patient on ATT. First, we need to be sure ourselves it's not a tumor, happening there, or some other disease process. In a patient of HIV, there can be a suppurative infection also. bacterial infection which can cause destruction of the vertebra and similar signs. It can produce not a cold abscess, but a proper abscess, around that thing. So we need to first of all find out what we are dealing with. So ESR, CRP, chest X-ray to find if we can find a primary focus there. So usually osteoarticular tuberculosis it is secondary, always. So there has to be a primary focus, which was there in this patient. Then after that, we get the MRI done and we see a epidural abscess or something. We find that the ESR CRP is raised, patient is having logical symptoms. Then we go and take a biopsy or take a sample of the pus. We send it for our CB-NAT examination for Zeal-Neiston staining. Once we are sure it is there, we start the patient on ETT.
So I would just like Dr. Soni has answered the question very well. Just to re-emphasize, always remember that try to get a sample from more accessible sites. Try to ask the patient to give a sputum first. If the patient can give a sputum, get an X-ray. If the patient can give a sputum, nothing like that. It's a non-invasive sampling. We could have in that cervical lymph node, we could have said the FNAC for a CB-NAT to find out the resistance pattern. And then if you do not have any other site, as Dr. Soni said, you can always take out a sample. You can take it out from the collection. You can take it out from the cold abscess. And it's always a good idea to find out what is actually happening. So somebody from ART, Nakapalli saying we should consider iris. Yes, when I summarize the case, I did say it looks like a case of iris. Yes, it is definitely iris. And then somebody is saying why complete rest is necessary. So please could you answer that?
So complete bed rest is necessary. First of all, we do not want that instability because there is always destruction of the vertebral body also. TB starts with a disc problem. It starts from the disc. So it is called as tubercular discitis. Once the tuberculosis destroys the disc, it moves on to the vertebral bodies. Okay, and it starts destroying the bone there. Once the bone destroys, the disc destroys, the vertebra starts tipping. When it starts tipping onto the next one, it causes a kyphotic deformity. That means now the spine has become unstable, right? Slowly it will go on to the other parts of the vertebra and slowly starts eating on the joints, everything, producing more and more instability. So what happens in an unstable structure where a soft tissue like a cord, soft tissue structure like a cord is very, very, closely involved with. So if the entire architect of the bone is destroyed, the entire pressure will come on to the cord. Once that starts happening, the logical symptomology starts happening at that time, or it starts becoming very rapidly progressive. So if we have kept the patient in bed, or if we have not, patient doesn't require to be in bed, is mobile, but still he or she has a sort of a splint, we are basically giving support and rest to that part of the vertebra. And meanwhile, the ATT is helping in treating the disease. The disease has to go. It has to disappear or become cured for the healing phase to start. Once that starts, once the ATT starts working and the vertebral destruction is stopped, we can slowly start mobilizing. During that period, to avoid complications, to avoid the kyphotic deformity to progress, we ask the patient to be in complete bed rest.
So I hope you got the answer. Are there any other questions?
Is there, Dr. Nishant, is there any role of steroids in trying to prevent the sequelae, because there's so much inflammation happening at the same time?
Dr. Ananya, see, steroids, yes, initially, if we see a lot of cord edema, okay, and we see epidural edema, we can advise the patient on steroid. Steroids only for a little while, but not much role. ATT and complete bed rest and follow-up of the logical status is the most important. Steroids are not going to help much. Yes? Okay.
Thank you so much.
Bye.
People taking time for us. So that was actually a very, very interesting talk.
So we had an excellent presentation today, and for us to make this presentation even more, we have all these lectures on our YouTube channel. So I would request all of you to go back to them and you go through them in your free time. And I hope all of us learned something and we'll be in a capacity to serve our community better.
Meanwhile, we will tell you the answers of the MCQs. Yeah. So the first question was the treatment of choice for the PLHIV developing TB spine is option A was the right answer is B, ART and ATT. The second question was the commonest region of the spine involved in the TB spine is the correct answer is dorsolumbar spine.
Thank you all of us for joining today. And I thank everybody, and especially thank our case expert, the case presenter today, Dr. Babu. Thank you for sharing such an excellent case for us and so that we could have a thoughtful discussion. Thank you so much.
And thank you, Dr. Ananya. And I would like to thank Dr. Upasna for the moderation of this session. And I thank Dr. Soni, Dr. K. Babu, and all our participants to join. Thank you so much.
Thank you.